Thank you, Tom, for that very nice introduction. A little on the embarrassing side, I'd say, although there are no funny pictures. Those two playmates in San Diego, by the way, are Hoyt and Shackford, in case anybody was wondering. I also appreciate the opportunity to come down here and speak. I've been following this conference since its inception, 5 years ago. Watched it grow, and it's a real delight to be down here, participate in it. I'd like to thank Drs. Salvino, Notrica, and Ree for the opportunity, and the program committee for the opportunity to come down. What I'm going to talk about this morning are pitfalls, and I don't want you to think I'm an expert in pitfalls, because I've had more than anybody else. I haven't necessarily. It's something I've had an interest in since back in my younger days, I used to fly airplanes and learned some of the discipline of analyzing the errors we make and correcting them. Of course, in general aviation, little mistakes lead to big problems, and it's our problem because it's our rear end that's on the line, unlike medicine where it's usually the patient's. I'm going to start with an aviation analogy. I think you remember the so-called miracle on the Hudson, where Captain Chelsea Sullenberger, having had a bilateral goose strike to the engines, landed a powerless plane in the Hudson River shortly after takeoff with no injuries, no major injuries, and no deaths. It was deemed a slight miracle, but of course Dr. Sullenberger's response was, we're trained to do this. This is what we do. It's like no big deal. Contrast that with Air France 447, which you remember in June 2009, in severe weather over the Atlantic, encountered icing. Pitot tubes were clogged. They went into a flat stall and crashed at 126 miles an hour, killing everyone on board. Things didn't quite go so right there. The near as anybody can tell, a lot of this is attributable to a combination of mechanical failure and pilot error. And speaking of pilot errors, we're the pilots in this business of medicine. And we have to, I think, pay close attention to some of the lessons we've learned from aviation, and a little bit of that I'm going to talk about this morning. There was another incident, it's a little closer to home, I think most of you remember. This is the Asiana crash that happened a few months ago in our neighborhood. And this was a little bit of a miracle, too, given there were 307 people on board and ultimately only 3 fatalities. We just discharged the last patient from the hospital a couple weeks ago, one of the flight attendants. So I'm going to talk about the subject of pitfalls and traps and the management of major trauma, and I'm going to divide this talk into 2 portions. One is just a general consideration of errors and why things go wrong, what it is we do, what are the environmental, the internal, external, and latent factors involved in our environment that leads us to sometimes make errors. In the second half of the talk, I'm going to give some specific clinical examples. It gets a little dry talking about theoretical error management, just so you have an understanding of the types of things that can go wrong with specific clinical entities. And again, I want to emphasize I haven't had more pitfalls than anybody else necessarily. It's just, again, something I've been interested in. Just to define terms, a pitfall is an unapparent or hidden source of trouble or danger, a hazard potentially leading to errors and adverse outcomes, just so we are all clear. I think everybody's seen this chart. This is derived from some of the error theory. This is the universe. Do I have a pointer up here? Maybe it's this. Oops, nope, that's not it. Is there a laser somewhere here? Anyway. You look at the squiggles up at the top, that's the universe throwing off challenges or threats. And we're protected by all these layers of Swiss cheese, but when things like the surgeon and equipment and patient is easy to diagnose, etc., but when things start to go wrong, i.e. the surgeon's fatigued, the equipment's faulty, patient has latent comorbidities, there's a brand new anesthesiologist and inadequate staffing, you get an adverse event. It's a risky business we're involved in. There are 2 so-called high reliability enterprises in the world. Anybody know what they are? Any guesses? They're the ones you'd want. I'll give you a hint. Number 1 is nuclear power, and number 2 is commercial aviation. Everything else is not considered a high reliability operation. And what we're involved with is by no means a high reliability operation. These are some of the classifications of threats: external threats, environment, patient condition, occult injuries that aren't apparent on initial presentation, comorbidities, often not apparent at all or even known, changeability in everything, all the environment, the staffing changes, the equipment availability can change, patient volume can surge. All those are external threats. Internal threats, those of you that work in teaching environments like I do, it's constant internal threat. They're called house staff and medical students, and all these wonderful individuals who we're so committed to, but who are learning their job for the first time every 2 months. And it's a constant stream of educating, training, and then doing it all over again 2 months later. It creates a variable teams of providers and resources with a potential for inaccurate or untimely communication. Fatigue is less of an issue now that we've adapted the so-called 80, now going to more like 60 work hours per week. Conflicts, proficiency is a big challenge. I think most of us believe, and apparently most of the program directors believe too, that the 80 hours has compromised the proficiency of many of the house staff. They are still great people, but they simply do not have the exposure that they did 20, 25 years ago, and oftentimes the proficiency is lacking. Some of the latent threats: lack of training programs, lack of policies, lack of protocols, risky equipment. And the thing that is perhaps one of the most challenging features of what we do in trauma is we have a low volume, high acuity of injuries. In other words, if you look at a lot of things in surgery and medicine, they're high volume, low acuity. You get pretty good at that. You get pretty good at doing simple operative cases, hernia repairs, lap choles, even people that are doing more high risk cases like cardiac surgeons, you're doing similar operations day in and day out, lots of coronary artery bypass grafts. Whereas trauma, by definition, the most serious injury, the highest risk injuries occur very infrequently, which is a challenge to keep everybody's skills up, particularly the house staff. This is a clinical example of an actual case that occurred at our institutions quite a few years ago now. This is a motor vehicle crash patient, 40-ish years old, came in with altered mental status as a result of the crash, Glasgow Coma Score 13, went to the CT scanner. I'm leaving out a lot of the details, and this demonstrated what was deemed by neurosurgery to be, in retrospect of course, to be a high-risk subdural. They looked at this, the attending looked at this, said this one's going to be trouble. Now, this wasn't communicated back to anybody. Radiologist didn't recognize this because it was a junior radiologist reading the film, and this occurred in a setting of high volume, high acuity period. Our ED sometimes looks like the bar scene at Star Wars, and this was one of those kind of nights. I'm sure everybody's familiar with that. It was the end of the shift. Everybody was tired. We had a whole lot of per diem staff who were good people but very unfamiliar with some of the routines. So those are the external threats. The internal threats: radiology resident was inexperienced, lack of knowledge, was not supervised by a senior radiology attending, a problem we still have at certain times of the day. Multiple services were involved. That creates communication barriers: neurosurgery plus trauma plus the ED plus radiology. The ED staff was fatigued due to all this high volume and the per diems, et cetera. And the latent errors were inadequate per diem training programs. Many of the nursing staff, some of the ancillary staff, were thrown into the deep end, and our emergency department is definitely the deep end. There was no protocol or policy for expediting high-risk traumatic brain injury patients. Trauma rooms weren't designed to accommodate more than one patient. Our trauma rooms accommodate one patient, not two. So what happens? They had all these patients in the hallway flowing out the door. Patient was doubled up in a resuscitation room. Monitors were switched. The patient in question was put on one monitor and an uninjured patient put on the other monitor. And people got very excited about the one, but not so excited about the other. Progression of subdural, progressive obtundation, airway obstruction, respiratory arrest, secondary hypoxia, transient hypotension. Guess what? Things didn't turn out very well. So the errors involved in this, you can see where the external, internal, and latent threats are. Inadequate communication regarding the high-risk status, failure to recognize high-risk nature of the TBI, radiology, and neurosurgery, and to communicate this back to the people caring for him in the ED. Inadequate monitoring of the patient upon return to the ED. Failure to follow procedures, 2 patients, 1 room. What were they thinking? And improper use of the monitoring equipment. Ultimately, the big critique was nobody nobody said, wait a minute, we are in a high-risk, dangerous situation here. We've got too many staff, too few staff, too many patients, too high acuity, no one's talking to each other, we've got doubling up in trauma rooms, and no one did the timeout. We are in a high-risk, dangerous situation. So there was not the opportunity provided to identify the error, correct the problem before a disaster happened. This is a preventable death. And this is the schema that some of the so-called crew resource management, it used to be called Cockpit resource management. This guy named Heimrock, who passed away not too long ago, was down in Texas, who developed the whole concept following a L-1011 crash of Eastern Airlines years ago, flew into the Everglades. Some of you may remember that. And the pilots were occupied with a landing gear light that was malfunctioning. And the plane was on autopilot, and quite a few people were killed. This was the stimulus for developing the science of cockpit, later on termed crew resource management, which looked at how we identify errors, how we capture and trap errors and prevent them from leading to adverse events. And you can see down here in the lower portion, we've got error detection and response, and when that happens, most of the time, not always, we can mitigate the situation and the outcome is inconsequential. If that doesn't happen, then in this case, this is paraphrased from some of the airplane stuff, aviation, induced patient or airplane state, management, and again, if the management is appropriate, it's inconsequential, otherwise you get an adverse outcome. And of course, one set of errors can lead to another set, and the whole thing can snowball. I'm sure you all know are familiar with the snowballing phenomenon, where something small leads to something bigger, leads to something bigger. So there are a lot of analogies between commercial aviation and medicine, and a lot we can learn, I think, from the study of commercial aviation and how they analyze, very carefully dissect these types of human errors. This is an interesting graph. This is an external observer's rating of teamwork in aviation and surgery. You can see poor is green, yellow minimal, orange standard operating procedure, and pink is outstanding. In cockpit, almost no poor, probably a little more minimal than one would like to think about, but most of it's either standard and a fair amount of excellent. And you shift down, surgery within the team is not bad, actually. Anesthesia is not so good, but then between surgery and anesthesia, you can see a lot of poor, a lot of minimal. About half is poor and minimal, and half is standard or outstanding. So 50% of the time, the teamwork between anesthesiology and surgery is lacking. And this is, again, the reason why we have these simulations, both in the ED and the operating rooms, to try to improve this teamwork. This is another one I thought was interesting. Commercial aviation medicine, effective when fatigued. These are report surveys from nurses, surgeons, and pilots. So are you effective when you're fatigued? And of course, you know, the folks in medicine say, yeah, 60, 70% of the time, yeah, I can just power through any degree of fatigue. My decision making is good, and you know, everything's fine. You look at the pilots and they recognize the impact of fatigue, and only 25% of them or so are saying they're effective. Their decision making is still pretty good. And the last one here, juniors should not question decisions by seniors. Happily, that's not as high as you might suspect it to be. The nurses are lower, the surgeons, of course, are the high, and the pilot's almost zero. Now, you may remember I think most of you probably can remember the Korean Airlines plane that was shot down. It was Flight 007, as it turned out. It was shot down circa 1983 by the Russians when it allegedly strayed into Russian airspace. Well, there's pretty good evidence now that the inertial navigation systems, there was no GPS back then, the inertial navigation systems for that airplane were misset by the pilot. And that the juniors, and this is all long before crew resource or cockpit resource management came about, the juniors, one of the juniors had given some indication that they recognize this, but no one questions, this is an Asian culture, no one questions the pilot. So the pilot, the chief pilot, and there were apparently 3 senior people, the chief pilot was allowed to misprogram the inertial navigation system, which led to the deviation. It wasn't corrected in flight, flew over Russian airspace, and boom, a whole bunch of people were shot out of the sky. So the juniors should not question, or anybody should not question, is a real important characteristic of this kind of teamwork. This is a good example. This is a study out of JAMA in October of 2010. A lot of you probably seen this. Looking at the association between implementation of a medical team training program, surgical mortality. This is 108 VA hospitals. Now, they have their own unique flavor, of course, but nevertheless, this is a big population. 182,409 patients, OR teams. Look at 2 months training, a conference, and then a year of coaching, and then looked at the no team before and after, change in mortality after a year, 18% reduction in mortality. Interestingly, there was a 7% reduction in the control, which speaks to the Hawthorne effect by the salutary effects of just simply studying the problem. A reduction in risk-adjusted mortality is 50% greater for trained facilities, and for every quarter, trained facilities had a reduction of half a death for every 1,000 procedures. That's pretty good for medical team training and surgical mortality. And a lot of these, of course, were higher risk cases. These were not lumps and bumps kinds of things. But it speaks to the issue of, again, undertaking training mechanisms or practice, or in your own practice, elements that will tend to promote teamwork, particularly in the OR between the anesthesiologists and the surgeons. So I'm going to go through just some examples and potential, some of the team failures. This is resuscitation. How many of you out there either work or spend some time in the ED? Show of hands, a fair number of people. So this is directed at resuscitation, less so in the operating room. And you're familiar with these. Failure to establish leadership. Failure to report current patient status. How often does that happen? Call out what's going on, tell us what you're thinking. Failure to report therapeutic plans. Failure to report unexpected changes, which is why ATLS constantly harps on reassess. Lack of receptivity to team input. Remember a case years back, anesthesiologist said the patient's, there's a little bleeding up here. It's a little bleeding, multi-polytrauma patient, had a huge scalp black, was essentially sanguinating from a superficial temporal artery laceration. Well, he's bleeding, finally said, could I have few more towels up here for the floor? And that got everybody's attention. So it speaks to the issue of lack of receptivity to team input. Resuscitation, this is inappropriate workload distribution. Everybody here's probably resonates to this a little bit. Inadequate staffing. I think we're all inadequately staffed, aren't we? I mean, at least 80% of the time. Insufficient training, a huge problem now. And I find this to be a particular problem in our residency training. If our residents in most programs, we do what I call ex officio credentialing. In other words, if you're a PGY2, by definition, you're qualified to put in a chest tube, start a central line, do all these kinds of things, where in reality you may not have had appropriate experience. Now, 20 years ago, it wasn't even an issue. You probably put in dozens, if not hundreds, of chest tubes as an intern. Now these kids coming through are maybe putting in 1 or 2, and they're expected to know how to do it, and they're simply not proficient at doing that. We've had problems, and I've seen problems in traveling around with this type of thing. Volume saturation, other patients. This is one of the key notions why we worry a little bit about over triage, particularly at centers that are resource centers. You over triage, you volume saturate the institution, you produce a lot of distractions that are really not good for the trauma team and the trauma personnel taking care of the really seriously injured patients. Inadequate supervision, this certainly applies to us at teaching hospitals. Conflict resolution, we've got leadership conflicts. Who's going to be the team leader? Who's going to actually make the decisions? Management conflicts. I want to do this. No, you want to do that. Patient needs an endotracheal tube. No, they don't. Frustration or hostility related to inadequate performance. Team members that are expected to know how to do X and in fact are not proficient. And scope of responsibility conflicts. Inadequate physiologic monitoring, inadequate lab monitoring. Failure to recognize shock, ongoing blood loss. And I'll show you a few slides. You'd think, how could this happen? These are, we're talking level 1, level 2 trauma centers. These are at the pinnacle of our healthcare pyramid in terms of taking care of trauma. How could we do this? Failure to recognize shock, ongoing blood loss? Incomprehensible. Failure to recognize incipient respiratory failure, neurologic deteriorations, as an example I just pointed out. Now, in aviation, we have a term called situational awareness, which is just the global situation. You're aware of everything that's around you. You're aware of your instruments, not just one of them. You're aware of the airspace, where you are in space, the directions you're heading, the speed, other traffic in the area. And the same thing applies to taking care of a trauma patient, situational awareness. You're aware of your assets, i.e. your team members, You're aware constantly of patient condition, changing condition, etc. And there are lots of stumbles to be had when situational awareness is lost. Ambiguous information received. Fixation on one goal or problem. And this is right out of aviation. It's one of the causes of in junior pilots, including JFK Jr., in crashing the airplane. If you remember, he went into a death spiral off the coast of Massachusetts, flying a relatively high-powered general aviation craft. Wasn't trained to do that, and became focused, typically as people do, on a single instrument. So you're flying, you focus in on airspeed or altitude, and you can't do that. You have to focus on the entire panel, otherwise you will get into a death spiral, everything will look good, and you crash into the ocean. That's essentially what happens to flight Air France 447. So fixation on one goal or problem. I'm measuring blood pressure, it looks like it's okay. I'm not watching much else. Confusion, anxiety, discomfort. Failure to adhere to standard operating procedures. I thought we could get away with it this time. How many times have you heard that? Failure to resolve discrepancies between data, between findings, between studies. Failure to communicate. Failure to, it sounds simple, doesn't it? Failure to manage the patient. In aviation, we say, first of all, fly the airplane. It sounds really simple, but it means fly the airplane. It's stick, rudder, airspeed, attitude, manage the patient. It's blood pressure, it's neurologic status, it's all these things. And people do become confused with the myriad of input and the amount of data that they have to assimilate, particularly if they're inexperienced. Well, there's a lot of going on with classification errors. I'll go through this fairly quickly. There are lots of different ways to classify this. Error taxonomy, type, domain, cause, impact, preventative strategies. This is something that the Joint Commission is pushing now, where all the trauma centers are gradually, I think, moving towards this. So type is diagnosis, management errors, etc. Domain is where it happened. Cause is this cognitive, the underlying psychology with the error. Impact is how bad, what was the result of that error. And then developing preventative strategies. So it really is kind of the essence of some of the performance improvement we do. From cognitive theory, input errors, so we've got incorrect receipt or perception of data. Okay, I'm doing everything intention and I end up with doing something wrong. A lot of the errors that were made initially when laparoscopic cholecystectomy was being brought out were input errors. People were developing their own internal vision of where they were operating. I call it, in surgery, I call it lost in space. You're lost in space. You think you're in point A and you're really way off in point C somewhere. But what you're doing is right. Your intentions are correct, but you end up doing the wrong action because of your input data. Intention errors, you got correct data, but your intention is wrong and results in a wrong event. And execution error, you've got the right data, you've got the correct intention, but whoops. And these are more psychomotor slips. I didn't intend to cut the ureter, I'm sorry. Rasmussen classification, and if you're interested in some of the studies of human errors, this is probably worth reading. It's a little dense. Rule-based, skill-based, knowledge-based, external wild cards, and then who knows, unclassifiable. And this is the one I like the best because, again, it's out of aviation. Errors in execution, these are technical, skill-based, psychomotor slips. So we call loosely, and you've all sat through, or most of you sat through surgical M&Ms when we're talking about error in technique. Most error in techniques are not error in techniques. Most error in techniques are management errors or judgmental errors resulting in a deliberate cut the ureter. I didn't see it, as opposed to something where you literally slip. Your hand slips, you make a nick in something. Those are psychomotor slips, and in surgery they're actually relatively uncommon. Errors in process, background, protocols, guidelines, these are rule-based. Well, I know the guideline says to do this, but I thought we could get away with it. Process errors, errors in communication goes without saying, errors in decision-making, you just don't have adequate situational knowledge. You're making mistakes based on personal biases, on risk-taking, and we all know that risk-taking among surgeons is a big factor in how many complications we have. Surgeons, and you know who they are, there are surgeons out there who are going to push the envelope, take some extra risks in the operating room. I thought we could get away with it. And most of the time it works out, and a lot of times it doesn't. And there are others that are more conservative. Perceptual errors, cognitive processes, misinterpretation and biases. People become focused. Again, this gets into the situational awareness thing. They become focused on one finding, one piece of data, and they create their own little construct as to what is happening with the patient, and their receptivity to additional input starts to decline. And finally, my personal favorite is intentional noncompliance. I just know what to do. I'm the heck with it. I'm going to do what I want to do. This is an article, and you can find this stuff online too, the Standardizing of Patient Safety Taxonomy. Go online and search this. There's a whole brochure you can download. This talks about the taxonomy, the standardized terminology. It's a lot easier said than done. It's harder to apply than it is to talk about. Impact, type, domain, cause, and prevention, both systems and human error, and patient, practitioner, and external. It's an interesting article. If you haven't read it, I would suggest that you do. These are some of the additional stratification that we use in our own PI program. We decide or classify errors as being retrospective, meaning the decision was reasonable given the data under the circumstances. There are always these so-called gotcha cases. One that comes to mind is one of my colleagues had a gunshot wound to the abdomen, and he went in there and operated to fix a hole in the small bowel or something. Maybe it was a colon, and went very carefully and explored the ureter. Meticulously explored the ureter. The patient did well, and a few days later developed a ball and perforated with a urinoma, and he missed the ureter injury. He said, I looked at that up one side, down the other. The patient had a duplicate ureter. He missed the injury in the other ureter. Of course, we gave him a bad time at M&M, saying, what do you mean you didn't explore the other ureter? What's the matter with you? So those are gotcha cases. So we say the decision was reasonable, he did what he should have done, but complication occurred. Prospective is really you should have known better. So one of my former chairmen used to say, it's on page 1 of the Boy Scout manual, you'd never do X. And those are things that are entirely avoidable. But the question in my mind is always, what were you thinking? I mean, we're dealing with highly intelligent, accomplished people. What were you thinking when these kind of things occur? Contribution factor to event outcome, and then overall impact factor from 0 to 5. These are some other errors that I noticed over the years. They occur sometimes more often than not. False attribution. You have an abnormal finding, but we're going to write it off to something else. So the patient comes in and their blood pressure is the classic, is the patient's blood pressure is 60. It's blood pressure cuff is malfunctioning. They're vasovagal. The nurse doesn't know how to measure blood pressure. I'm going to ignore that and pretend it doesn't, because you don't want the blood pressure to be 60. You want it to be, 160. So an abnormal clinical observation linked to an erroneous cause and incorrectly acted on or ignored. False negative prediction. You got a normal finding. Well, the abdominal fast was negative, therefore the patient couldn't be bleeding, and that blood pressure must be due to something else. So you have a negative predictive power of a test or study that's overestimated, and the fallibility is discounted. And then labeling, and I'm going to use a non-trauma case as an example. One of our esteemed medical historian years ago, a fellow named Chauncey Leake at the University of California, presented with chest pain. Just horrible pain. He was labeled as an MI. He had some minor EKG changes. Parked in the ICU after a few hours, of which he stood up and dropped dead from a ruptured abdominal aortic aneurysm. So he was labeled, everybody called him the MI in bed 6, and we see this all the time. If you aren't familiar with this, start to look for it. We tend to attach labels to patients based on presumptive diagnosis, sometimes based on very scanty information. And that's a dangerous practice, and I try to jump all over it, and the residents are annoyed with me for doing this, but this happens. We do it, we all do it to some degree. Never become married to a diagnosis. So this is a chart saying the relatively low incidence of failure-sensitive events. So anytime you see these big, large analyses of performance improvement, outcome measures, death, preventability, et cetera, well, most of these patients that we see are low acuity, low impact. They're going to kind of get better almost no matter what you do. There's another chunk that's failure insensitive. There are lethal injuries. The liver's ripped off the vena cava. There still may be opportunities for improvement, but the impact of the error is going to be pretty minimal. And then the failure sensitive, high acuity, high impact, where they really have to be so-called flown on the numbers. Everything has to go right. As a colleague of mine would say, you got to be having a good day to get out of that one, kind of thing. But these are the patients that we really have to examine. When I survey for the American College, these are the kind of cases I spend the most time with, are these high acuity, high impact types of situations that really test the ability of your center and your system to respond to all the various threats that are spewed out in the universe. So the challenge is most PI outcomes provide insensitive measures of system failures, creating durable structures for the analysis of error rates and error types, and a system that allows us to do that and compare these measures across the board. It's really a huge challenge. We have a taxonomy now. It's being applied with a high degree of variability, I think. Routine assessment of impact events and major overt threats occur infrequently. So these bad cases, these high risk, high sensitivity, low volume cases occur infrequently and are so variable that practice and specific solutions become unworkable. If you go back to error theory, they'll tell you the same thing. So which is why we have simulators for some of these, and it's why the pilots spend, every few months they're down at the simulator and they're flying, they're doing engine out, they're doing stalls, and the FAA just, as you may know, maybe you don't because you don't follow that stuff like I do, just issued a new directive based on the Albany crash last year that pilots have to have additional training in stall prevention, which is what exactly happened to that flight to Buffalo. The pilot made an error, acted incorrectly, and stalled the airplane out and killed everyone on board. So the simulation part needs to occur. We're not quite there yet with the high fidelity simulators, I guess. I'm going to just briefly look at some error recognition studies. These are some work that we did actually back in San Diego. Found that critical care errors occurred in 23% of all patients. It's awfully high. This is in a mature trauma system. 30% of patients who died and 48 of preventable deaths. Second study, 92. Errors leading to significant morbidity and mortality in 4% of all patients. 5.9 were considered preventable. The most common was failure to appropriately evaluate the abdomen. Again, this is in an established trauma system. Subsequent study, 94. Complication events occurred in 83% of patients. Provider-related complications in 22. So these are not, yes, this is a little bit older, but we're kind of seeing the same sort of thing. This is a striking slide. All these slides, this is out of LA County. So I understand since Dr. Ree left, all these numbers have gotten better. You out there, Peter? If you look at bleeding, sepsis, multiple organ failure, bleeding is the highest number. These are potentially preventable mortality in a mature trauma center. Similarly, you see delayed judgment, delay in diagnosis. Of course, bleeding, delay in diagnosis go hand in hand. Here's another one. This is out of a nice study out of Harborview in Seattle. If you look at the second two there, abdominal pelvic hemorrhage and thoracic hemorrhage, both are high. So we're making errors. I mean, stopping bleeding is what we do. It's the most fun of anything we do, stopping bleeding. And yet, not stopping bleeding is leading to these kinds of trauma mortality. Here's another study that Raleigh Vituri did down in Virginia there. Bleeding, resuscitation, 39%. So there's a message here that the thing that we are the best at, that we love doing the most, we're falling on our face in terms of making some of these errors. And another study showing airway fluid. You get the same flavor of all this. So that's kind of the whole error background thing. I'm just going to go through a couple of things real briefly in the next few minutes. Injury-based hazards, shock, pelvic fracture management, cardiac tamponade, and a few other things. So rule-based errors in the diagnosis of shock. You wonder why we make mistakes, but his heart rate's normal. He must be okay. He's talking and awake. But his abdomen was non-tender. Residents are always amazed when you open them up and they're circulating blood volume in their abdomen. He didn't have any tenderness. But the fast was negative, my personal favorite. He's making urine. His last hematocrit was okay. Oh, he's just vasovagal. Sorry. So this is an actual graph. I was involved in a medical legal as an expert evaluator, I guess. This is a 20-year-old guy that crashed his car going 120 miles an hour, presented at a pretty well-known level 2 center, surprisingly. And this is the graph of his systolic blood pressure over time. And you can see this is minutes on the lower graph, and out to about 165 minutes, this is a sawtooth pattern. This is resuscitated shock. So he'd drop his pressure, they give him a little more fluid, he'd come up, he'd drop his pressure. We call this transient responder. Well, the reason we get excited with transient response is you can only do that for a fixed period of time. This is a perfectly healthy 20-year-old, and down toward the end there, guess what? Dead. He died. This is a totally preventable death. He exsanguinated from fixable pelvic fracture hemorrhage. It was evident on the CT scan. But you read through the notes, but he's talking and he's okay. At least one reference to vasovagal. But the talking thing was apparently ignoring the fact that cerebral blood flow doesn't tend to decrease much below a pressure 60. This kid was a little anxious, but he was talking, he must be okay, right? Unbelievable. Ignoring this whole thing. So this could have been captured, hey, wait a minute, this guy's real, we need to do something about it, and resulted at least in a less consequential outcome. This is a nice study out of Canada looking at pelvic fracture, and I'm going to talk more about pelvic fractures tomorrow, so I'll probably skip through a lot of this. 85% of preventable hemorrhage deaths resulted in this institution from pelvic fractures. This is a real trap. I think we're getting better at this, but there's room for improvement. Failure to accurately assess the abdomen involved in some. Delayed control of pelvic fracture hemorrhage. We've got all these things at our disposal now, binders, angio, pelvic packing. Lack of massive transfusion protocols. Inadequate teamwork with anesthesiology, and a lack of a protocol's choreographed management scheme. So, this is just a plea for protocolized, protocol-driven management of these pelvic fractures involving the whole team. There's a study for a number of years ago out of, I think Walt was at Denver at the time, looking at mortality, death from bleeding, death from multiple organ failure with and without a protocol. Well, they obviously got a lot better. I wonder what they were doing before a little bit. A lot better with the advent of a protocol. There's another study from 2005. Everybody's past this point now, but it just says that if you don't have a protocol and you don't follow your protocol, it's easy to build one, but it's harder to implement it. You probably should. And this is the Western Trauma Association. You can see the OR exploration, pelvic packing, etc. That's pelvic fractures. Again, I'll talk a little more about that tomorrow. Cardiac tamponade, easy intubation. This is after one of our staff meetings, this picture here. Premature intubation, positive pressure. Usually it's in the back, actually, not in the front. Probably, sorry. Planning the chest incision, OR preparedness. There are false negative fast exams. We have to be very careful of those occasionally missed injuries. The trap here, though, is cardiac preload curve. Someone comes in with tamponade physiology, you give them 300, 400 cc's of fluid, and their pressure goes from 70, 80 up to 120, and you think, I made him better with that. No, you didn't. You just pushed the curve further to the right. The heart's still becoming ischemic. If you don't get that guy opened up, you're going to be in trouble. The other thing that happens in the operating room, we rush to repair the injury in a stunned myocardium, grab the heart, start throwing a suture in rather than just let it equilibrate. Pericardial tamponade is a compartment syndrome of the heart, basically. And when you open those things up, you got an ischemic heart. Be wary of that. Over resuscitation, this teamwork between anesthesiology. They think it's hemorrhage, and they've got a medical student squeezing the blood bags. And if you do that and you unprotect the heart by opening the pericardium, you will overdistend the ventricle, and it'll be hard to save these people once they get into trouble. Overzealous use of inotropes. They don't need a lot of inotropes. Usually they need sometimes a little bit of inotropic support. But you open the pericardium, decompress them. Most of these people are young. You've taken care of the problem. And again, poor communication. I think in the interest of time, I'm going to skip this one and go to pulmonary trauma. This is one of the more common problems I see when general surgeons who are not used to operating in the chest end up operating in the chest. Delayed operation, inadequate positioning, failure to obtain hilar control. Beauty of lung injuries is you've got proximal and distal control with one large Crawford clamp or twist or whatever you want to use. Superficial overshow of an injury tract. I haven't seen this in a long time. We've sort of beaten this out of everyone. I have seen it a couple of times traveling around. Inexperienced surgeon gets in there in this hole in the lung and it's spewing blood and air and oh my God, well, I can fix that. I just oversaw it. What do you suppose happens? Patient arrests about 30 seconds later from a giant air embolism. So don't do that. Performing convenience resection is a bad idea too. So the message here is air and blood don't mix. You got a hole in the bronchus, it's a big bronchus. You got a hole in the vessels. Oops, let me go back here. And blood in the airways is particularly bad for you. It eliminates the surfactant monolayer. It can produce ARDS. It does all sorts of things. And also air in the blood vessels is bad for you for obvious reasons. So air embolism, trapped lung in the parenchyma, exits via the pulmonary veins and causes cerebral embolism, an airlock, sudden cardiac arrest, etc. Occasionally you can get out of this if you deal with it quickly, vent the heart, clamp the lung, etc. But you got to be having, as my partners say, a very, very good day to escape from this one. And the endobronchial bleeding is real bad with alveolar flooding because of all the inflammatory responses you get. I think I'll skip over this. This is some of the traumatic lung injuries. This is a review. Basically, less is more. Mortality, sutures the best, tract is better, is not quite as good, wedge, lobe. And you do pneumonectomies, you're going to have very high mortality rates. It should be avoided almost at all cost. And this is one series looking at pneumonectomy with 100% mortality. So to summarize all this stuff, I hope those examples were useful. We work in a low, sorry about that, we work in a low reliability, high risk environment. Just face it. Read it and weep. We do. We're not nuclear power. We are not commercial aviation, and we are light years from being that. Human error is an inescapable component of medical systems of care. Recognize we all make mistakes. And it's just absolutely fascinating to me when highly intelligent, highly experienced, intelligent, accomplished people stick their foot in it. What were you thinking? And I do the same thing. I'm guilty as the next person. It's just fascinating the psychology of when we do things, and you go back and review your own thinking about things, and surprising what you find sometimes. Human error plays a large role in preventing trauma, deaths, and complications. Failure to reduce risk. We've done a lot. Everything now is patient safety, patient safety, patient safety, but yet we still don't train our residents and our fellows how to recognize potentially high-risk situations. We don't really train them. We talk about it a lot, but we don't really train them to do this. And finally, human errors really should ideally be more carefully analyzed and categorized, trended on a provider-specific basis. It's the area under the curve. It's the impact and the frequency. That's really what we ultimately want to get to, which I think will be the really good indication of how good the care we provide is. So I'm going to end there. Once again, thank you very much for the opportunity to come down here and give this Tom Wachtell lecture. Thanks a lot.